Welcome to the deep dive. Today, we're tackling a couple of really common signs we see all the time in practice, but they can be tricky. Inappetance and anorexia. For you, our veterinary colleagues, really getting a handle on these is just so key for managing our patients effectively. We've gathered some key insights from a really solid source, basically aiming to give you a shortcut to the essential knowledge on diagnosis, treatment, and importantly, when you might need more support. Okay, let's get into it. So first up, definitions. Let's just make sure we're all on the same page. Inappetence, that's a reduction in appetite.
Right, just eating less.
Exactly. Whereas anorexia is, well, a complete lack of eating altogether.
And the crucial thing is they're both non-specific signs, aren't they? They could point to almost anything systemic.
Absolutely.
Yeah.
And often they're kind of waving a flag for underlying nausea.
Yeah, that's a big one. It's also really important to differentiate these from, just a picky eater.
Oh, definitely. The fussy appetite.
Especially common in some small breed dogs, right?
Yeah.
You need to figure out if it's medical or behavioral pretty early on.
Good point. Okay, so when it is genuine appetence or anorexia, what are the big differentials we should be thinking about? Our source highlights quite a few.
Well, obviously the GI stuff comes to mind first. Foreign bodies, bad gastroenteritis, maybe even neoplasia or an intussusception.
Sure, the usual suspects.
But you also have to think broader. Things like inability to smell food, classic cat flu scenario. Pyrexia on its own can do it. Pain is huge, especially chronic pain like dental disease.
Right, often missed.
Totally. And then systemic diseases, renal failure, hepatic failure, pancreatitis, even heart failure or significant anemia. Neoplastic disease somewhere else in the body.
And those metabolic issues, too.
Yes, absolutely. Things like low potassium, high calcium, Addison's disease, hypoadrenocorticism, they can all present this way.
So, quite a list. How do you approach the workup then, clinically?
It really has to start with a super detailed history from the owner.
More than just, is he eating?
Oh, much more. Like, what percentage of his normal daily food is he actually eating? How long has this been going on? Critically, any weight loss, is he still drinking okay?
Those details really matter.
They're your foundation. Then comes the physical exam.
And it needs to be thorough.
Absolutely. Nose to tail, all systems, but really focus on that abdominal palpation. You're actively feeling for any subtle masses or abnormalities. Check the body condition score, assess hydration. It gives you context.
Okay, so let's say you do all that. History and exam are done. Maybe you've ruled out a diet issue, but nothing specific is jumping out. What's next?
Right. If it's still vague, then blood work is usually your next logical step.
What kind of panel?
A minimum database, really. Hematology and a good biochemistry profile. So urea, creatinine, liver enzymes, proteins, albumin, globulin. Electrolytes are key: sodium, potassium, calcium, phosphorus, and glucose.
Standard stuff, but essential.
Exactly. And don't forget urinalysis. A dipstick and specific gravity can be incredibly helpful, especially, say, differentiating pre-renal from actual renal kidney failure if you've got azotemia.
Makes sense. And if those are normal?
Well, if your bloods and urine aren't giving you answers, then survey x-rays, abdomen, and chest are often the next port of call, looking for things you couldn't feel or that weren't obvious on bloods.
Okay, so let's say you managed to pin down the cause. What's the treatment approach?
Fundamentally, you've got to treat the underlying disease. That's priority one.
Of course.
But while they're recovering, supportive care is vital. Encourage owners to offer small amounts of really palatable food. Warming it up often helps.
Like boiled chicken or fish.
Yeah, or those commercial convalescent diets.
Yeah.
They work well.
Yeah.
Hand feeding can sometimes tempt them. But, and this is important, tell owners not to force feed.
Why is that?
You risk causing food aversion. They associate the food with feeling bad or being forced, and then they really won't eat. It backfires.
Yeah.
And for hospitalized pets, especially cats, if they're just refusing everything, sometimes sending them home a bit earlier than you'd ideally like might actually get them eating again in their familiar environment.
That's interesting. So when does this cross the line from keep trying to we need urgent intervention?
There are some clear lines in the sand. Complete anorexia, absolutely nothing eaten for more than 3 days in a cat. That's an emergency.
Because of hepatic lipidosis.
Exactly. That risk is incredibly high and serious in cats. For dogs, the guideline is generally around 5 days of complete anorexia.
So what does urgent intervention look like?
It means hospitalization. They need supportive care, almost certainly starting with intravenous fluids to correct dehydration and electrolyte imbalances.
And then nutritional support itself.
Yeah.
How do we figure out how much they need?
Well, the goal is always enteral nutrition using the gut and possible. The calculation for resting energy requirement, or RER, is pretty standard for hospitalized patients. It's roughly 30 times their body weight in kilos plus 70. Gives you the baseline calories per day.
And how do we get it in?
Nasoesophageal tubes are actually quite well tolerated for short-term feeding. A few days, maybe. Easy to place. Syringe feeding can work, but only if it's done carefully by someone experienced, and you absolutely must stop if the animal resists or gets stressed by it.
Back to that food aversion risk.
Precisely.
What about drugs? Appetite stimulants?
Yeah, they definitely have a place. For cats, IV diazepam can sometimes work short-term, though it's less common now. Oral options like cyproheptadine or mirtazapine are used in both dogs and cats.
And mirtazapine seems quite popular now.
It is, yeah. And if you suspect nausea is the main driver, then anti-nausea meds like meropenem or metoclopramide are your go-tos.
What about B12?
Vitamin B12 injections only really help if the patient is actually deficient, which you'd ideally confirm with tests. It's not a general appetite booster.
Okay. And a really important point from the source.
Yes. Corticosteroids. They should not be used just empirically as an appetite stimulant. You need a diagnosis first, as they can mask underlying issues or cause problems themselves.
Good warning. And parenteral nutrition, feeding intravenously.
Generally, that's more of a specialist thing, not typically done in general practice due to complexity and cost.
Right. So, troubleshooting time. What if you found a cause, you're treating it, but the pet just isn't getting better, isn't starting to eat?
That's a definite flag. It means you need to reassess. Go back to square one almost. Repeat your physical exam carefully. Look again at those blood results, the radiographs. Did you miss something?
Could there be a second problem?
Exactly. You have to actively look for an additional underlying cause that might be complicating things.
Makes sense. Now, thinking about clients, investigations can get expensive. Any tips for managing costs?
Yeah, that's always a consideration. The most cost-effective route is obviously if you can nail the diagnosis just from the history and clinical exam.
Ideal scenario.
If you need tests, try to prioritize them logically. Maybe do them sequentially, step by step if the animal's stable enough. Start with the highest yield tests first.
And communication is key.
Absolutely. You have to be upfront with clients about the potential costs involved at each stage. No surprises.
Finally, when should we be thinking about referral to a specialist?
There are a few clear indicators. If the patient just isn't responding to your efforts to encourage eating despite treatment, or if your in-house diagnostics haven't yielded an underlying cause and you're kind of stuck.
Right.
And also practically, if your practice just doesn't have the facilities or maybe the staffing levels to provide intensive long-term nutritional support for a patient that needs it, like prolonged tube feeding.
Knowing your limits.
Exactly. Referring in those situations is often the best thing for the patient. It's good clinical judgment.
Okay, so we've really covered the spectrum here, from recognizing inappetence and anorexia through the diagnostic process, management strategies, and knowing when to escalate.
Yeah, and applying these kinds of strategic points, the things highlighted in our source material, it really can make a tangible difference to how well our patients do and, how satisfied clients are with the outcome.
Definitely.